We are here with Dr. Tony Choueiri to discuss some of the wonderful genitourinary cancer abstracts that are being presented this year at the 2019 ESMO Congress. Dr. Choueiri is the director of the Lank Center for Genitourinary Oncology, director of the Kidney Cancer Center, senior physician at Dana-Farber Cancer Institute, and the Jerome and Nancy Kohlberg Chair and Professor of Medicine at Harvard Medical School. Hi, Dr. Choueiri. We're so happy to have you here today.
Thank you, Gina.
It's been a really great start to the ESMO Congress so far this year. There's been a lot of very interesting RCC abstracts. Can you first talk about the data we saw this morning of the entrada trial with telaglenastat with everolimus in advanced metastatic RCC? So could you walk us through that trial and the data?
Yeah, that's an interesting concept, an interesting drug, and we do need actually new target in renal cell cancer beside VEGFR, mTOR, and the PD-1, PD-L1, and CTLA-4 inhibitors. And this target is related to the glutamine metabolism, and we know in cancer, we know now for over 100 years, the shift that occur in cancer metabolism, and the dependence on glutamine, as well as other processes. So this is a glutaminase inhibitor with interesting preclinical data to back targeting this pathway in cancer. And as a proof of concept, this trial looking at the combination of this drug, the glutaminase inhibitor, with everolimus versus everolimus alone as a control arm. As a proof of principle, that trial is positive, and the authors concluded that the combination is superior. I agree with that. However, one of the things that this is a very small trial, and the control arm everolimus didn't do well compared to what we and others reported on. There were no responses practically, very few, less than 5%, and the progression-free survival with everolimus was on the low side. Nevertheless, I think this is a proof of concept. The combination was tolerated. And what's interesting is that there is a much larger study with cabozantinib as backbone called Cantata. So we're looking forward to this study results.
Oh, all right. That should be a very interesting one.
Yeah.
So how about the final results of the TiNivo trial, in which tivozanib was combined with nivolumab in patients with metastatic RCC? What's exciting about these data?
Yeah, absolutely. Another very interesting combination in line with combining a PD-1 inhibitor with VEGF-TKI. Tivozanib is one of those very selected VEGFR inhibitors, and recently showed superiority over sorafenib in the refractory setting for progression-free survival response rate. And just recently, actually, the hazard ratio for overall survival, something that plagued this drug for a long time, became less than 1. In this study that presented at ESMO, the combination resulted in good response rate, over 50% combination, which you expect less with each drug alone. And the progression-free survival, despite this was small study, 25 patient, I believe, showed was more than 18 months with tolerable side effects. So hopefully this will be taken to the next stage.
Great. And with tivozanib, we recently saw an updated OS analysis. Can you kind of walk us through the history of this drug and its interesting timeline it's had so far?
Yeah, very interesting history. Again, one of the most potent VEGFR and clean VEGFR inhibitor, initially developed in the frontline setting against sorafenib, and despite winning on progression-free survival with a favorable safety profile, the hazard ratio was for overall survival was more than 1. And this was attributed in large part to the fact that patients on the sorafenib arm were allowed to cross over to tivozanib and receive tivozanib. So there was an imbalance with one arm, if you want, receiving 2 drugs and another arm receiving 1 drug. With a lot of patients actually accrued outside the United States with less options at that time. So this drug didn't get approved by the FDA, went to an ODAC and didn't get approved. So the following study, the TiVo-3, came, and tivozanib against sorafenib, but in a refractory setting in patients that received prior VEGF-TKI, and a large number of patients received prior PD-1 inhibitors. And again, tivozanib did win over sorafenib in terms of response rate, in terms of PFS, primary endpoint. But again, the overall survival hazard ratio initially was a bit over 1. An updated result showed with more events coming in, more maturity of the data, that the overall survival was 0.99, less than 1. So hopefully there could be renewed interest in this drug coming. So we'll wait to see what the FDA will decide, how the path with this drug will be. And now we have data, very compelling data in combination with nivolumab.
Very good. Now, you're also on a couple of abstracts this year as well. Could you talk a little bit about the biomarker and efficacy analysis from Javelin Renal 101?
Yeah, so Javelin Renal 101 was a study that established the combination of the PD-L1 inhibitor avelumab plus the TKI axitinib as superior combination compared to sunitinib, and led to the approval by the FDA. And in this two sub-studies that we presented, we look at patient with or without prior nephrectomy, and we looked at patient with or without prior sarcomatoid component in their tumor, which we know these are aggressive patients. And the combination was found to be superior irrespective. Something that I'll be presenting is the sarcomatoid histology, which we know it's not a proper histology. These are features present with every present even in clear cell RCC, and they're anywhere between 10 to 15%. And these patients historically were poor responders to VEGF-TKI or even to mTOR inhibitors. But now there is renewed interest because we're seeing responses and we're seeing enhanced activity with checkpoint blocker compared to TKI. And there is a lot of biologic rationale. Increased PD-L1, increased CD8. There is also a immunosuppressive profile that these tumors have underlying, but checkpoint blockers work better, and I think there should be standard in this histology. Now, what type of regimen remains to be determined, but we know now that these patients with nivolumab and ipilimumab benefit much more than sunitinib. Same thing with pembrolizumab, axitinib. We showed now with avelumab and axitinib, atezolizumab and bevacizumab. So definitely, I would say frontline option with a patient with sarcomatoid histology should have a checkpoint blocker.
All right, thank you. So what about other abstracts being presented in RCC this year? What else are you excited about?
So one area I'm really interested about is always totally novel target. So one target of particular is HIF2. So this was kind of an Achilles heel that was almost impossible to target because it's a transcription factor. This is really from a chemical biology and organic chemistry very hard, to target till investigators and researchers not long time ago found a compound that can actually inhibit HIF2. And this was presented, actually the first generation was presented last year, and this year we presented the result from the second generation, a drug called PT2977, which is a HIF2 inhibitor that recently was acquired from Peloton by Merck. And Dr. Eric Jonash and myself will present the data showing in a single agent activity over 20% in a very highly refractory population. So those are population that treated with VEGF-TKI, PD-1, median number of prior line of therapy 3. Response rate 24%, PFS 11 months. With an interesting enough, because when you start talking about a new target, you want to see how you combine these drugs. So you want to look at their toxicity. And actually, with the HIF2 inhibitor, there was some anemia, some hypoxia, but we didn't see the hypertension, the diarrhea, these VEGF class effect, a significant fatigue. So it seems to be quite well tolerated, hopefully promising for future combination.
Great. So moving away from RCC for a little bit, and let's go into some of the bladder cancer data that's being presented. So one that's eagerly anticipated is the IMvigor 130 trial. What do you think we could learn from the data when they're presented here?
Yeah, I think, we know that chemotherapy work in urothelial cancer and checkpoint blocker work. So we long anticipated combining chemotherapy with checkpoint blocker here, gemcis or carbo plus atezolizumab. So we have to see again the magnitude of the benefit. We would love to see something more so about overall survival, and would love to see something prominent about overall survival. The results in the lung cancer are there, and in non-small cell lung cancer with pembrolizumab, and it's quite, impressive. So I think we want to learn two things. We want to learn what is the magnitude of the benefit for PFS, for OS, for response rate, ultimately for OS. And second, if the magnitude of benefit clinically is not that high, if there is subgroup, and I automatically think about those patients with IC2 and 3, with significant PD-L1 expression, are they the patient we should target with the combination? So quite exciting, and I'm happy that this will be presented at this meeting.
And we've seen some interesting novel targeted therapies being explored too in urothelial cancer. So there's some data with enfortumab that's going to be presented. We saw data this morning with sacituzumab govitecan. What are your thoughts on some of these more novel agents being explored?
Absolutely, and you say it better. I call them EV and SC. So antibody drug conjugate in bladder cancer are here to stay. So you just have the right drug with the right antibody with the right delivery system, and then you can see results. And both antibody drug conjugate are promising. EV is well ahead in its development, and we saw a trial led by Dr. Holmes that combined EV with pembrolizumab in cis-ineligible patients with quite an impressive response rate, 71% and over 90% tumor shrinkage. And seems that the combination could be tolerated. So one wonders if this combination is going to take over, let's say, pembrolizumab and cytotoxic chemotherapy. So that's quite interesting. I mean, the other combination, with SC, use a payload with irinotecan-like SN38, and also showed very interesting response rate with, as expected, hematologic toxicities, and should be moving forward along the same line. It will be interesting in the future, in my opinion, to see how do patients that progressed on EV do with SN38 payload and vice versa. And this remains to be seen.
Dr. Choueiri, thank you so much for being here today and sharing all of this insight with us. We really appreciate it.
Thank you. Thank you for having me.
Of course.